going to be regarding cases that are found or enhance the care by means of 3D imaging, having radiography, have 3D. Before we get to the 3D concept though, I want to show you a couple of extras. This is about, I think, a 7-year-old female patient. And this patient is in a family of very high dental IQ, very compliant with their dental care, and they were doing everything by the book, and everything was done by the book in this person's dental office. This is an example of the cases that fall through the cracks. Occasionally, things go wrong. And this is a patient who had all the fluoride treatments necessary and everything, but they had the lesion you see here on their left angle of the mandible. That lesion probably had been there for a good 2 or 3 or maybe more years. But because the protocol for caring for these patients calls for bite wings and occasional periapical x-rays, these lesions were not detected until they developed a swelling in that area. So those are the cases that fall through the cracks. That unfortunately is the price to pay for the way that statistics work. If she had had a panoramic radiograph earlier, then that lesion would have been picked up. This turned out to be a Neuroblastoma fibroadenoma, which is a happy ending for an unfortunate situation. It's a benign odontogenic process. But still, it's something that we wish we had picked it up earlier because it's easier to treat. It doesn't involve worrying about the nerve or the neurovascular bundle in that area. Here's another example of a patient who had cherubism. So I don't know if you can see with the light that there are some multilocular radiolucent lesions on the angles of the mandible. Also another lesion or lesions that were not picked up by routine bite wings and PAs. So their panoramic radiographs to me are excellent screening tools, and I'm pretty cheap to order x-rays on pediatric patients that come to see me or jaw lesions or swellings. Here's our first case for this last section, and this is a lady who has had asymmetry of her mandible for quote a few years. Not a very compliant patient, very dental phobic, and this patient came in forced by her mother because they could no longer understand her speech. This is how her picture looks like intraorally. So she had a jaw lesion that was growing enough to push her florid mouth past the area of the normal level, and her tongue now lived on the second floor of the dentition. So it was at the plane of occlusion and above. She couldn't enunciate well, she couldn't phonate well. So I just wanted to show you the clinical before I show you the x-ray of this person. So this person has a pretty world-class lesion here. Welcome to North Carolina, or North Carolina x-rays. And this individual had a mixed radiolucent radiopaque lesion. So basic concepts: if you have a hunk of bone and there's a hole in it, when the x-rays goes through that bone, it's going to burn the receptor more, so it's going to make it darker. Anything that looks darker is negative space or air or void. Anything that stops the x-rays more than the expected area is going to be radio opacity, and it's going to look white because the receptor was not burned on that location. So this lady has a mixed radiolucent radiopaque area, and in this situation, her diagnosis was enhanced by us knowing this x-ray presentation. So you can see here that she had a relatively well delineated lesion, but this lesion went backwards quite a ways. This patient, her genioglossus tubercle was essentially poking upwards, and her tongue was a problem because she would choke and she would have difficulty sleeping as she essentially had sort of like a pseudo sleep apnea when she closed her airway because of that. So a CT was a useful tool in this case because we were able to localize this lesion. After the biopsy, this turned out to be an ossifying fibroma, which is a benign process, but it can be locally aggressive. This ossifying fibroma needs to come out. There's just no way about it, unless she wants for that thing to keep growing. If we keep that area in place, it will continue to grow until it's just monstrous. But this individual, after having an actual CT, another of the useful things of three-dimensional imaging is that it allows you to construct stereolithic three-dimensional models of the patient's jaws and lesions. This is something that can be done off of the volume or the data of the volume of CTs and cone beam CTs taken in the office. And this can be fed into a 3D printer that will then print you this model, allow you for visualizing that before the patient goes to the operating room. But also, now you can have customizable bars for reconstruction of this area. You can calculate the volume of graft material you're going to use for these people if you're going to use graft material. You can pre-plan a lot of the surgical steps and the reconstruction of these people a lot better with three-dimensional imaging. So unfortunately, this person had no more bony support that was sound to hold her, and this is what happened to her. So her jaw ended up in a bucket, and then we needed to do something. So thanks to this stereolithic model, the reconstruction bar that was used for this patient was pre-bent. It saved her anesthesia time and a lot of time in the OR. And so ended up, after going from this, going to this, right now she's got this issue with that bar that's there, but at least she has a fighting chance of eventually getting a graft. In this case was chosen to not be reconstructed immediately. So this case is going to require a little time for some wound healing and management of that area before grafting and doing what they do. So this is a case that some people would have opted for immediate reconstruction. So there's bioosses out there, there's different grafting materials that are used for these type of processes, and that's the beauty of having all the information on a case before you make the first cut, because you can plan the reconstruction much better and choose the materials, and also give patients realistic expectations of what's going to happen to them down the line. So that's a case in which 3D imaging was very useful for the model and for patient education and to get this plan well. Here's another example of a patient who had an expansile lesion of the mandible, and this individual, upon biopsy, turned out to have an Neuroblastoma, which is a benign but locally destructive lesion of enamel cells that don't quite make enamel. They're kind of like in the first degree of differentiation. So on the right, you see the biopsy procedure as it's going. Here, you have the difference in quality that you can see from a regular panoramic radiograph on the left and a reconstructed panoramic radiograph on the right from the volume of a CT. And it is significantly more improved. But importantly, once you get your three-dimensional imaging, you are able to assess the integrity of the cortex of this individual's bone, and also to see if there's perforations of this tissue, and mark the margins a lot more precisely than 2 dimensions. So when you have these nice little 1 millimeter thick slices of the jaw, you can design and manage your patients much better. This is the same concept of having a bread like a baguette. If you imagine a baguette, and you see the baguette through like that, you will have a bidimensional image of that. If you slice the baguette in thin slices, and you take each slice like that, you can see where the holes are, and you give that to your brother. And then you keep the one. So this type of three-dimensional imaging is also useful because the software that you have allows you to measure very well the volume of the tumor. This is useful for malignancies. Occasionally, chemotherapeutic agents and antibodies are given to patients based on the tumor volume. So we need to know the volume of the tumor to allow for dosaging of some of the medications. This is a benign tumor, it doesn't require chemotherapy. But a lot of the things that it does is it measures, and it also helps with the surgical plan. The software allows you to localize where the neurovascular bundle is. So when the surgeon goes in to manage this lesion, they will know where to expect the nerve, and they will know how many, sometimes millimeters or microns, are between the lesion and the nerve, or if they need to tell the patient preoperatively that they're very sorry that that nerve is probably going to have to be sacrificed. So that's very useful information when it comes to managing patients through pre-surgical stages. Another example of the same thing, one critical thing that allows or gives us information is three-dimensional imaging lets you see the third dimension of a jaw. So a panoramic radiograph will allow you to see in this way. A reconstruction of a CT allows you to see the slices in this direction. So just like the loaf of bread that I told you, this image here on the top left, the little yellow lines, I think they're yellow, the little yellow lines are tiny slices of about 2 millimeters that are reconstructed on the bottom panels of that. So you can see how this lesion is behaving in a three-dimensional arrangement. And then for patient education, 3D reconstructions are very useful as well. Patients are not used to seeing a 2D reconstruction of their x-rays, but they know how a skull looks like. When you show them that that's their skull, it's not a model, but it's their skull, and you tell them this is the lesion, this is where the nerve is, they understand what's going on. And in my experience, when we allow for patients to understand their lesion, their compliance with management is much better. When patients own their lesion and the information, if they see it, if they visualize it, you are in the same team against that lesion, and there's a lot better compliance, a lot better understanding, because most patients, when they have something like that, they don't know what's going to happen. It creates a lot of anxiety, and this helps a lot to guide them through it. So here's another example of a patient who had a neuroblastoma, and this is the panoramic radiograph of this person. So that is a pretty good size lesion, if you think about it. And I couldn't help to add some x-rays of neuroblastomas here. Histologic pictures. So I'm not going to bother you with the information about histology, but I just think they're the trick. Here's another example of a patient who ended up with a lesion, and this is a take-home message. If you have a patient who has a soft tissue lesion that is adjacent or in contact with bone, take an x-ray of that bone, because this is what happened in this patient. So what you saw on that first one was the tip of the iceberg, and the iceberg actually was a huge lesion in the mandible. Obviously this was a palpable mass, but this is how intraorally it would look like, and with an x-ray it looks like that. A cone beam CT was, actually a CT was done to gauge this lesion, and ended up being quite a dramatic result. This is the x-ray of this patient 3 years prior to that lesion. So retrospectively, maybe you can see something in there. At the time that this was initially seen, nobody saw it. But a three-dimensional image would have seen it, because it looks at the other dimension of this medullary bone, and it would have picked it up. This is already too late, and this is the same patient. You can see the destruction of this bone in this area. There is perforation of the cortex, and there is destruction all over. Again, for patient education, you show them this three-dimensional reconstruction on the right, and they understand what's going on. You can rotate these, and you can show them the cartoon of their jaw or bone or maxilla or whatever they're having to deal with. And unfortunately, this biopsy turned out to be a plasmacytoma. She had 2 sites that turned out to be multiple myeloma, which is a problem. Couldn't help to show you a little bit of histology again, but that was a case that was useful to have that. This is another example that we had, and this is an unfortunate patient who had an osteogenic sarcoma or osteosarcoma of the maxilla. This patient had a cancer that the cells were bone-producing cells. So this individual ended up with a lot more bone production in his maxilla. The panoramic radiograph showed that stoppage of the x-rays as they couldn't pass through the tumor. And intraorally, he also had an expandable mass. So the x-ray bidimensionally shows this. Here's the three-dimensional image of that. The first few cuts, or the first ones that I'm showing you here, are the bone windows of this volume. So this volume of data, that is all the zeros and ones that a cone beam acquires from the x-ray, are translated into images. And depending on how you apply the formula and the algorithm to this data, you can tell the CT machines and the software to enhance calcified tissue, or to enhance soft tissue, or to enhance enamel or nerve. So these are bony windows that are going to help you decide and look at the detail of the bone. These are soft tissues which will help you decide or look at the detail of the soft tissues. So you can have flexibility on that a lot. And cone beam CTs are a little behind than medical CTs on soft tissue, but they're getting there. The algorithms are getting better. So we're getting to somewhere. This is that same patient I just showed you with the osteogenic sarcoma. And three-dimensional imaging allows you to see that this man's lesion actually incorporated into the orbital floor. And that means that this patient's orbital floor needs to come out. And you can see on this other orientation that the tumor is trickling up in three-dimensional volumes. Here's another orientation of the same thing. And so this thing is overtaking the entire craniofacial skeleton of this individual. And this would have been clinically silent until it pushes the eye up or until it gives this patient nasal discharge or pain. But it is thanks to three-dimensional imaging that we're able to localize these lesions and tell the boundaries of where they are and how they involve other locations. So very, very significant advantages of three-dimensional imaging. My dream for three-dimensional imaging one day is that instead of us having to take a full mouth series and a pan, patients will go in the office, park themselves in front of a cone beam machine or some sort of office CT and have one thing around their face in 5 seconds. And you can then design all the x-rays from that volume to fit your needs. We're not there yet. We're not quite there for caries detection, especially in the proximal. We're not quite there yet for fine detail, but hopefully down the line, that would be a cool thing to have. That would be really cool. Here's another example of a patient whose chief complaint was, my denture doesn't fit anymore. Typical example. That's another thing that I hope you get out of these talks is patients who wear dentures need follow-up. That's a good service to your patients. So this patient's denture didn't fit anymore. This person had gone to a place that didn't even bother taking an x-ray before they made their dentures. And you can see on the upper panel, there is the reconstructed panoramic view of this thing. And on the lower ones, you see how this lesion is mapped on the cross-section of the mandible. So this is really powerful tool for planning. This was important because it allowed us to realize that this lesion had not perforated through the cortex, and that if you had an intact cortex on a cystic lesion like this one, you have a very good chance of getting around it without poking through and ended up making a mess. If this was a cancer or a salivary gland lesion, for example, or a lesion of significant biologic behavior, we will have to take up to the next tissue plane to cure this patient. Because the periosteum is intact and the cortex is intact, this was a cyst. This patient ended up having a simple curettage with grafting, etc., and a couple of extractions. But this is another example of why the denture was not fitting anymore. Somehow that cuspid decided to pop out of the cortex. So this was an area where pain was occurring upon pressuring that tooth. So a little gross picture here of the cystic specimen enucleated. This is larger than it looks. And then microscopically it was just a cyst, but it had some glandular features in it. This was a glandular odontogenic cyst that they have mucus cells in it. And by them having mucus cells, they inflate themselves in a relatively aggressive manner, and they occupy space. We don't know why this person had that activation of that mucus cystic cell later in life and not earlier, but it happened very frequently. It crosses the midline. So that's that patient. Here's a patient in whom a panoramic radiograph sort of pointed out something. If you look at this patient's left ramus, there's something there. And I'm going to show you a little close-up of that. And I see a lot of heads like that. We were like that too. So this is an old case back in the day when this was on film, the CTs. So this thing had a multilocular bubbly type of lesion in that area of the jaws. Here I'll show you a close-up view of that. And that's a good look of that, but you can see that there's multiple little bubbles of this thing. When you see the other orientation of the area, you see how extensive that is compared to the relatively non-extensive looks of the panoramic radiograph. Luckily, all surgeons are trained to shove a needle in things before they enter lesions in the mandible, because this lesion turned out to be a hemangioma. And if they had opened this patient just willy-nilly, they would have ended up with a seriously bleeding lesion in this patient. And so microscopically it looked like this. This was a hemangioma. And another example of when radiographs do you a lot of favor. Here's another example of a patient who had fibrous dysplasia. This is not a challenge to diagnose on bidimensional x-rays. But look what happened once we had a CT of this patient. This, by the way, these two pictures are not the same patient. But this is what happened in this individual. This person had multifocal areas of fibrous dysplasia, effectively making it craniofacial fibrous dysplasia, not just monostotic. And that is a huge difference. That's a huge deal. This patient also had little brown pigmentations on the skin, and you guys are already going into the differential diagnosis for McCune-Albright syndrome. And some of these patients will develop malignancies of glandular origin. So that triggers a good workup for these people. A cementoblastoma is another lesion that once we see it, we always require or recommend to have three-dimensional imaging of this patient, because we need to make sure that that bony lesion is stuck to the root. Because if it's stuck, the tooth is coming with it. If it is not stuck, some people will have a fighting chance of taking their tooth or leaving the tooth in place, because occasionally central ossifying fibromas overlap on top of areas of dentition, and they look like they are based in the root, but they're not touching it. That's the beauty of a three-dimensional image that will allow you to see a connection. If there's a connection, it's a cementoblastoma. Either the root or the tooth is coming out with it. If it is not connected, you can take the lesion out and leave the tooth. Here's another example in which three-dimensional imaging is excellent. And if I ever had a lesion like this, called Staffney bone defect, I will definitely have a cone beam or some kind of 3D imaging of my jaw to make sure. What happens here is this, in Staffney bone defects, as you recall, bone resorbs by means of responding to pressure. So if you put pressure on periosteum and bone over a long period of time, or on PDL and bone over a long period of time, that bone is going to get out of the way. And that's how you can move a tooth. That's how you can do different movements of bone and orthopedics. Well, the salivary gland that lives in the floor of the mouth, in the posterior aspect, the submandibular gland, occasionally decides to live a little large than it should, and it puts pressure on the cage of the bone, on the lingual cortex of that area. That pressure induces resorption and architectural changes that create a hole. Remember that when we have less bone than in the adjacent areas, you are going to have darkness or radiolucency. That is just space that's occupied by the gland, but if you didn't have a three-dimensional image to conclude that that is the gland and the cortex is normal, then many times these patients end up having a biopsy of that lesion for a simple staphylococcus defect. Here's another lady that had a two-dimensional finding in a panoramic radiograph. She hadn't been to the dentist in a long, long time, and she ended up going back to the dental office. A panoramic radiograph was taken, and she had this on the right posterior angle of the mandible. That, on a three-dimensional image, turned out to be an osteoma that was going immediately towards the airway. If it had grown a little bit further, it could have been a problem with swallowing and eating. But this lady also was worked up, because once you find an osteoma radiographically, you have to do a little workup, just in case they have something like that. This patient had a condition called Gardner syndrome. And this individual with Gardner syndrome, or people with Gardner syndrome, have a mutation of the adenomatoid polyposis coli gene, or APC gene, that induces or predisposes them to have colon cancer, almost 100% incidence by age 30. So these people have a prophylactic colonic resection before age 30 for that. Another situation in which X-rays and three-dimensional images are useful is traumatic bone cysts. Sometimes a person who is going to have a radiolucency of their jaws, and it is discovered incidentally, most 99.9% of these lesions don't hurt. When they are open for biopsy, it's an empty cavity, and now, by experience, people know that if you have an empty cavity and there's no lining in there, and there's no tumor or mass or tissue in there, then if you create some bleeding in that area, it fills with bone clot, and once that bone clot fills, it's going to heal. And monitoring of this is very useful. Here's another example, a very sad example of a young patient. She had vanishing bone disease, or Gorham syndrome, and this is a progressive degenerative problem in which bone literally just melts away and disappears. So this poor lady ended up passing away related to this condition. So her whole mandible disappeared. And let's see. So that's what I have here for you for the radiolucency. I want to show you a few cases of some other things. Because you are in hygiene world, I want to touch base with a little bit of periodontal lesions as well. So lesions of the periodontal. I'm going to go a little faster because I know I have to get you guys out of here around lunch, but I can't resist. So you know the periodontal, you know all the cells, you know all of that good stuff. Here's the normal mucosa, epithelium on the top, connective tissue at the bottom. And then this is the menu of things that could happen in the periodontal tissues of people. And here's a list of things that can happen. Things that don't usually happen in the periodontal of people are lipomas and salivary gland things, because we don't have fat tissue in attached gingiva, and we don't have salivary gland tissue in attached gingiva. We have it in the vestibular mucosa, we have it in the palate, but in the actual attached gingiva, we don't have fat, we don't have salivary glands. It is nearby, but it's not there. So the first few lesions I'm going to show you are reactive lesions, and let me show you a prototype of a reactive lesion. Obviously, you guys are ready to go and clean this guy's mouth. This guy hasn't been to a town in a long time, much less to a dental office. But this person has a single bump on the gingiva. And here is a little sequence that I like to suggest to follow for my residents when they see lesions like that. So you identify it, you ask around, you check it, you always want to put your fingers on it. If it is near the bone, you take an x-ray, you look for local causes, and you try to start doing your algorithm of workup with that thing. I know that you're already jumping into that looks like a pyogenic granuloma, and that's what it is. But it's a prototype lesion that we can use to work up some things. And of course, there may be some surprises along the way. So this is what you do. This is what you're trying to do, a history, symptoms, and you work up through this little baby ladder of steps on how to do that. And at some point, you're going to have to deal with this thing either surgically or mechanically or one way or another. But you're going to develop a list of possibilities of what this lesion is. And one way that is very easy to come up with a list of possibilities or a differential diagnosis for any lesion is to think back to your days in school. That is why we teach histology to people and anatomy to people. Because if you look at a lesion like this one, and you try to remember what normal tissues live in that area that if they were to go berserk could end up looking like that, then you will have a very good differential diagnosis. So if we do that exercise, cells in that area are going to be either epithelial, fibroblastic, inflammatory, endothelial, osteoblastic, osteoclastic, neural, or odontogenic. Those are the cells that live there. Notice there's no fat and salivary gland tissue. So if you take this circle one step outward, and now you get these cells and turn them crazy, you get with the other circle. So you will have periolesions rather than periocells, and you can have hyperkeratosis if it's epithelium, or you can have fibromas or anything that's fibroblastic if it is fibroblastic, or you can have a fistula if it's inflammatory because of pus, or you can have a pyogenic granuloma if it's endothelial cells, a peripheral ossifying fibroma if it is osteoblastic, or a peripheral giant cell granuloma if it is osteoclastic. So if you know the cells that live in that area, if you turn them crazy and look at think of the lesions that they turn into, you have an automatic differential diagnosis of how to deal with this thing. Based on these differential diagnoses, you can design management of what to do about that. So here is a lesson that we all learned when we were teeny tiny little kids. If something got in our shoe, did we go home and then put 3 more pairs of socks on top of that? No. We stop, we get the rock out of the shoe, and then we keep on going. That's what we have to do for lesions in the mouth. If you think that a lesion in somebody's mouth is reactive, stop, get the pebble out of the shoe, and let it just self-correct. If somebody has a reactive lesion like this pyogenic granuloma, get the irritants out of the way, get everything in an environment that's promoting healing, and then most of the times these lesions are going to either self-correct or shrink to the point that they are a little bit easier to manage surgically, or if they don't, then you just have to deal with the bigger lesion. But if you can give a chance to reactive lesions to self-correct, that is excellent. When you practice, or when you help or cure a patient without prescriptions or without surgery, you are practicing excellent healthcare. That's very important for you to remember. Not always you need to cut. Not always you need to prescribe. Sometimes all you need is to get the pebble out of the shoe. So here's a fistula. If you cut this fistula off, or if you apply a topical steroid on that fistula, or if you do anything to that fistula is going to laugh at you. What you need to do is find that pebble. So pull test the teeth, probe the depth of these things, and there's a bad tooth in there. They get a root canal or take the tooth out, and then that fistula is going to self-correct. Just That's one of the messages of today. So here's how a fistula would look like under a microscope in my alter ego. Microscopically, that's how it looks like. A lot of pus in a little hole in the center, and then flowing. So this was a fibrous. That's how it looks like under a microscope. Lots of little blood vessels, vascular spaces here, endothelial cells all over the place, and this is secondary to irritation. This is another PG. Here's a peripheral giant cell granuloma. So if you think back to the PDL days of histology in school, the cells in the PDA, or the PDA has stem cells in it. And these adult mesenchymal stem cells that live in the PDL, if they get stimulated, so they make Sharpie fibers, they make all of these things, and they make occasionally calcifications. If the stimulus to these stem cells in the PDL induces the cells to differentiate into osteoclasts, the ball of lesion that's going to come out of that thing is going to have osteoclast in it. That would be a multinucleated foreign body type giant cell or osteoclastic giant cell, and the lesion is baptized as peripheral giant cell granuloma. If the cell is osteoblastic in origin, is going to make bone, and the lesion is going to be baptized as a peripheral ossifying fibroma. So depending on what signaling gets given to the stem cells, there'll be osteoblastic, OFF, or osteoclastic PGCG. Occasionally, some peripheral giant cell granulomas are going to have a central or intrabony component. So every time you see a patient or a lesion that is diagnosed as PGCG or POF, you need to take an X-ray of these patients and then look to see if there's a central or intrabony component to this lesion. Because occasionally, central giant cell granulomas or peripheral or central ossifying fibromas are going to mushroom out of the bone into the gum and show up like a peripheral lesion. But they're just, what happens is you're just cutting the tip of it. So always take an X-ray of PGCGs and pause to make sure there's nothing down there. And there's been a few reports in which peripheral ossifying peripheral giant cell granulomas have been associated with hyperparathyroidism, just like central giant cell lesions or brown tumors. So here's a peripheral giant cell granuloma. Here's a peripheral ossifying fibroma. In these cases, a three-dimensional X-ray will probably show you some speckles of calcification in that area. Be careful of the recurrences of these things. If the lesions are excised, but the irritants are still present, that pebble is still in the shoe. So the job of the hygienist in this case, the job of the surgical specialist will be to remove this lesion. The job of the hygienist will be to make sure that this lesion and the surgical site heals with no trauma at all. If there is trauma to this same area, there'll be a recurrence of the lesion. So that's the ossifying component of a peripheral ossifying fibroma. The stem cells got stimulated into an osteoblastic pathway. Here's a slightly larger OFF, another OFF. Interestingly, some of these lesions, especially POFs, are going to have a very, very small stalk. And the lesion may be large, but once they're removed, the actual stalk is really little. Sometimes they're very broad base and they are going to encompass wide areas of the gingiva, but sometimes they're tiny. So here's a couple of examples of lesions that had a smaller base than it looked like in that area. Same thing, make sure that you take an X-ray every time you do one of these lesions. Fibromas are not as common in the attached gingiva as they are, for example, on the buccal mucosa or lip, but giant cell fibromas can occur occasionally there. Here's another fibroma of the gingiva, another one. And all they are is balls of collagen. They're essentially sort of like keloids of the mucosa. And that's that. So then we have some cystic looking lesions. I don't know if this is going to show that well. I don't even see it. So here's one. This little baby lesion here, the most common clinical impression I get when they are sent to you in a biopsy is mucousy. Remember, there's no salivary gland on the gingiva. So if you see something that looks like a mucocele on the attached gingiva, is most likely a gingival cyst, a lateral periodontal cyst bursting out of the cortex into the gingiva, or occasionally a lymphangioma. So those things, I recommend that you guys biopsy those lesions. This is a gingival cyst of the adult, normal mucosa on the top, the cyst in the middle, and it's very, very easy to cure by removal. If you don't remove it, it will recur and recur and recur. So mucoceles don't occur in the attached gingiva. Make sure that that is ruled out as a cyst. Occasionally, these lesions that show up in the gingiva like these are the same tip of the iceberg, and you will have lateral periodontal cyst or botryoidal odontogenic cyst or glandular odontogenic cyst that are going to be bursting out of the cortex onto the gingival tissue. So they usually are unilocular elusive cysts, well delineated, usually anterior mandible or premolar region. Firstly, they look like that. So a tooth comes out with that little goober on the side, and that is a lateral periodontal cyst. Here's another one of the same things. So lateral periodontal cyst, very typical histology. I'm not going to give you that at this point. Here's an infant who had a finding that was a gingival cyst of the newborn. This was a similar scenario, only it had a little bit of keratin, and it was in a little baby. Tiny little lesion here. And this actually showed up more like an expansion of the alveolar ridge. This patient had this problem. So she had that expansion. The radiograph showed a lucency that was larger than the area. She also had skin brown macules. This patient had neurofibromatosis, which was very important for us to realize. And she got a workup for that. Here's a neurofibroma also that is over there. And occasionally, things that look like fibromas are not. And here's another example of smokeless tobacco. You probably have seen this one before. I may have shown you some mucous fibrosis, a neuroperiodontal lesion that we need to make sure that we address. These patients with some mucous fibrosis occasionally and actually frequently end up with scar bands that make them have very limited opening. So it's very hard for them to clean at home. It's very hard for you to do oral hygiene, dental hygiene with them. And they are considered a risk factor for cancer. So critical for us to know. Marginal leukoplakias. If there is no reason for these people to have this marginal leukoplakia, say they use a at-home Profi cup and they just jab it in there and let it roll, or they are avid flossers, if there is no explanation for this needs to be excised and looked at, because occasionally people will have proliferative verrucous leukoplakia that can be a precancerous change. I've shown you this. This is the histology of that squamous cell carcinoma. And this is another example of a squamous cell carcinoma of the gingiva. Here's another example of a squamous cell carcinoma involving the gingival tissues. So I think I've just about killed you guys with information. I'm probably going to stop there and see if we can answer a couple of questions. But I really appreciate you sticking around, and thank you for your attention.